I guess we'll just start.
Yeah.
You guys are both fellows?
No, I'm a PA.
You're a PA. You're a PA intern. So what's that mean?
So I'm like a PA student with a license.
Okay. And so it's like the equivalent of like a surgical intern. You finished.
Exactly.
And now, are you going, is this like just a rotation? Or are you going into critical care?
I'm considering going.
Okay. So it's like a rotation. This is 1-year rotation. And you are?
I'm a fellow.
Okay. And what did you train in?
I did pulmonary from Ross Center.
Pulmonary?
Yes.
Okay.
1 year.
Like, so you did medicine, then pulmonary, then critical care. And then what are you going to do?
That's it.
Okay. We get a job.
Hoping for and then job.
Okay. So, since there's only 2 of you and
Some
a couple more, we'll do this as a lecture, but also, like, please just jump in with any questions because there's so many different things you can focus on with trach. And so, you know, some of this is going to be really basic and some of this maybe you don't know and you want to talk more. So, you know, the more interactive this is, the better. Okay. So basically, trachs have been around forever. Everybody's going to come into contact with trachs. It's actually, the more you know, the easier it is to care for these patients. It's not that difficult. But a lot of times people are scared because the idea of a trach scares them, and that leads to more morbidity and mortality, and it leads to provider anxiety. So obviously, the trach is used to change the flow of air. Instead of air coming in through the nose, through the mouth, it comes in through the trach. Now, while going right into the trach, there's not a lot to worry about. You are near things that are worrisome. You know, normally you put the trach between the second and third tracheal ring, but that is right near the carotid arteries, the innominate. The thyroid gland would sit right over this. The esophagus is right behind this. The larynx is right above it. The current laryngeal nerves are right there, and the cervical spine is right behind it. So while there's really not a lot to worry about if you go straight in, if you go a little bit off, there's a lot to worry about. I don't want to get too much into the terminology, but people will fight forever about tracheotomy versus tracheostomy. In general, the otomy is just like any otomy. It's a surgical creation of the opening, and the ostomy is the formation of that opening and it often implies like a more permanent, as opposed to just doing it like a flash trach. People could argue that forever. Cricothyroidomy is where you do it in between the cricoid and the thyroid. The advantage is usually easier to feel. The disadvantage is the vocal cords are right there, and you have to revise that or you're going to damage the vocal cords. Percutaneous dilational trach is where you do a trach using percutaneous dilational technique, and a laryngectomy is different. It's removing the whole larynx as opposed to just doing a incision into the trachea, and it looks different, and we'll go into that at the end because there's sometimes some confusion. Real quick, trach tube components. You have the obturator, which is used to insert it, the inner cannula, the flanges, fenestration, which is on the back, and the cuff. And there's really just 4 main divisions: cuffed and uncuffed, fenestrated, unfenestrated, single lumen, double lumen, metal versus plastic, and then there's whatever brand, which is a lot of things. So cuffed versus uncuffed. Here you have one with the cuff. Here you have one without the cuff. The cuff is obviously used to make a seal in the airway. When you have the cuff up, all the air that goes in the trach comes out the trach. When you don't have the cuff up, the air that goes in the trach can come out the trach or can come up and come out the mouth. And so the advantage of that is there's obviously less room for secretions. It's more narrow. So if you don't need to do positive pressure ventilation, this is probably, the uncuffed is probably the better bet. If you need ventilation, the cuffed is the better bet. Fenestrated versus unfenestrated. The fenestration is referring to the hole right at the top. And in some cases, let's say you have a big trach in, or you have someone with tracheal stenosis, or they have a tumor, so things are tight to the trach, and not a lot of air can get around the trach. If you have the fenestration, it allows the air to go up through the trach. You almost never see a fenestration and a cuff together. There's very rare situations where that could be possible. And then single lumen versus double lumen, and I'm not talking about the double lumen like the thoracic people put in within the tracheal tube. Here, most of these have an inner cannula and an outer cannula, and the inner cannula goes in, you take it out to clean, it can be disposable, you can take it out and throw it away. And there are some single lumens where there is no inner cannula. The advantage of that is these are often more flexible, and then the ratio between the outer diameter and the inner diameter is smaller. So if the inner diameter is larger for the same size outer diameter. Whereas here, you lose something because you have two pieces of plastic. So the inner diameter and your airflow is therefore less. The advantage of this is that if this gets clogged, what do? You have to pull it out and put in a new trach. And so that can be very difficult. The advantage of this is that if it's clogged, you pull it out, you clean it, and you put it back in. So you very rarely, in kids where you're dealing with small airways and the difference in, by losing extra diameter, getting all the way to the inside would really get you down to a small amount. Sometimes you see single lumens. In adults, you almost never do. And then metal versus plastic, you almost never see metal anymore. The advantage of the metal is that the inner diameter is a little bit smaller than the outer diameter because the metal is a little thinner. I mean, a little bit bigger the inner diameter for the same size outer diameter because the metal is thinner. And you can use these forever. You can take them out, you can sterilize them, you can put them back. So someone could have two of these at home and just change it every day and keep one in hydrogen peroxide and it's cleaner. But they get dinged up, they get bent. It used to be a much bigger thing, now it's not. All of these have mnemonics, not really mnemonics, they just have labels. The LPC is the low pressure cup, is the most standard one. None of these make any sense and they're very hard to figure out. So you just have to memorize them. Passamure valve, that's a one-way valve that you see. You guys in the ICU aren't going to see that, but a lot of times if you have someone who has larynx cancer and they're obstructed and they need trach for that, but they still can move a little bit of air, this is just a one-way valve. And all it is when you breathe in, air comes in here, and when you breathe out, it pushes some paper against the front or some plastic, and no air goes out, and that way you talk through your mouth. So it's very, very basic, but it allows you to speak hands-free. Remember, I just said stop anytime, ask any questions. So why do we do trachs? The indications have changed over time, and the details vary place to place, but the general idea is the same, and there's three main reasons. The first is this is what you guys deal with by far the most, is ventilator dependence, prolonged intubation. The second is the inability to handle secretions, and the third is you have some airway obstruction. And usually, almost all trachs are one of these three things. So like I said, by far the most common is ventilatory dependence or prolonged intubation. And if you're going to provide long-term ventilation, it's more stable than an endotracheal tube. You avoid the complications of the long-term intubation. You don't have a tube going through your cords that can hurt things, and it improves patient comfort. You don't have a tube that's in your mouth. You just have it in the neck. It also is very useful for weaning from the vent. It decreases the dead space. That doesn't make a big difference, but if someone's right at the edge, it can make a difference. And the trials of extubations are easier. You can pull someone off, and if they fail, you just put them right back on. You could pull them off for an hour, put them right back on. You could pull them off for a day, rest them at night. And so it makes the extubation, especially again in a tenuous person, easier. Patients who have trouble with secretions, a lot of times it could be neurologic, it could be traumatic, it could be from a coma or something, head injury or a head and neck surgery. They don't swallow well. They have a stricture, and so esophageal stricture, so all their secretions build up. And then it improves pulmonary toilet. It lets you suction. Now, there are some studies that show that it may not actually decrease aspiration as much because there's negatives. You don't build up a good cough reflex. Your positive pressure when you cough, you close your glottis, you build up pressure, you open your glottis, and you can forcibly expel things. You can't do that with the trach in place. So if you aspirate, even if you aspirate less, you might be less good at clearing the times you do aspirate. And then mechanical obstruction. This is just the list, but it could be anything. It can be congenital, subglottic cyst. It could be traumatic, infectious, neoplastic. That's what I see the most. And the gold standard of people with terrible obstructive sleep apnea is the trach. And you don't do it very often, but if someone's morbidly obese and they got big tonsils, and that's the best way to handle obstructive sleep apnea. You can plug it during the day, unplug it every night. And so this is a big meta-analysis. They looked at adult patients undergoing trachs, and what you could see is that by far it's just the medical issues. Congestive heart failure, pneumonia, COPD, cerebral vascular accident, like the type of things that we were talking about, upper airway infection or true vocal cord paralysis, just are much rarer compared to what you see. So just to sum up some of the advantages of trach compared to oral intubation, you can move them around, more secure airway, more comfortable, better suctioning. You can get them out of the ICU easier. That's something you don't really talk about, but that was part of the impetus of us setting up the thing here. It was delaying stay in ICU. There's less endolaryngeal injury. You can eat. You can't eat with a tube in your mouth, but you can eat with the trach in. You can communicate better. You can't talk with an ET tube in well, but you can talk with the trach in. And then decreased airway resistance, and in certain subgroups, decreased pneumonia. Again, any questions, any thoughts, anything you want to go into more detail, let me know. So different types. You have the open trach. That's a standard surgical trach. That could be done at the OR. That could be done at the bedside. Essentially the same procedure. There's percutaneous dilational trach. This is almost always done at the bedside. And there are some different techniques for that. I'm not going to go into too much detail on the different techniques, but most of them use the Seldinger technique. So what that is that's over a guide wire. How many of you guys have done perc trachs? What are you? You're a fellow?
Emergency resident. I mean, I'm just like.
We are both from the dark program.
We just saw.
We just saw, like, you know,
doing
like,
bedside.
like we used to be there sometimes for bronze.
And I hear that somebody.
You used it, right?
Yeah, well, when I was at Sloan, we did
Yeah.
we did trachs.
You did perc trachs?
Yeah.
So usually historically we've done most of the trachs. We've done them all open, mostly at the bedside. I hear now that in the CSICU, one of the general surgeons is doing it, and then I hear that some of the Pulm people are going to start taking you guys through perc trachs. So the key, and I'll go a little bit into the literature of the advantage, but just in the procedure, is you have to use direct visualization. All the studies show that when you don't use direct visualization, the complication rate is very high, clearly higher. And so you need to look and make sure that you're placing, that you can see that you're in the right place. So what you do is you insert a needle with a sheath, you remove the needle, and then you insert a guide wire through that, and then you just sequentially dilate over that guide wire with bigger and bigger dilators. One of those dilators is the trach. You remove everything, and you're done. So this is it. You can see. This is what you should be looking at. You should see through the tracheal rings that you're in the right place. You pass the guide wire. You pass the trach. You pass the dilators. Then you pass the trach at the end. And this way you can make sure you're in the right place and you're not putting it somewhere else. This is an open trach. We do it basically the same way each time. You make a vertical incision. There's a big argument, vertical versus horizontal. I always make a vertical unless I think the trach's going to come out in like 3 days. If you wait more than 2 weeks or a week, it all looks the same. You don't see the scar. It becomes a round scar. So I don't think if you wait for a while it makes a difference. A vertical is much easier, and is every slash trach you would do a vertical because you're avoiding the anterior jugular veins and you're staying right in the midline. And so to me, it's always just good practice for any emergency to do everything the same way. If I'm doing a case where I'm somebody has like an infection and I'm going to take it out in a couple of days, then I'll do it horizontal. But in general, I do vertical. You make your incision, you go through the subcutaneous fat, then you're looking at the strap muscles. There's two strap muscles, and there's a raphe. Sometimes they look like this. You can't really tell. They're right next to each other. Sometimes there's a clear space. But you want to take your time, find that raphe, because that way you stay midline. And the key is staying midline and avoiding all these other structures. I like to grab them with Alice clamps. I lift them up, and you have this fibro-fatty tissue, which takes you right down to the cricoid. And the cricoid is like your safety point. It's always relatively superficial. It's pretty easy to feel. There's not a lot over it. Sometimes the thyroid will come up over it. So I just bovie right onto the cricoid. Next thing is coming under the thyroid. You can see how much clearer the cricoid is when you do that. I bovie through the thyroid, and that gets you right down to the trachea. I make a horizontal incision in between the second and third tracheal rings. I don't expose any tracheal cartilage because, like, some of the basic science says that's how you get tracheal stenosis, is through infection, and by exposing the cartilage, I think you can increase that. And then you place the trach. If you guys had to do something emergently, you could do a cric instead of a trach. Very easy. Just feel it on yourself. Feel your thyroid cartilage. Feel right below it, and you're going to clearly feel a space. And that space would be a space that you could do a trach pretty easily. I would say all the flash trachs I've done, because I wind up not doing a cric, I just go below it, and that way you don't have to revise it. But I think it's easier to do a cric, especially if you're not familiar. The disadvantage, you can see the vocal cords here. So if you do a cric, you have to revise it, or else the trach is going to cause inflammation and vocal cord scarring. Postoperatively, this is not really for you guys as much, but just got to keep a trach care kit, suction kit. So always good to keep the obturator there. If the trach falls out, you want to be able to put it back in. Gentle suctioning, clean the inner cannula, and skin care. This is something that really is debated. When do you change the trach? Historically, people changed it like day 3 to 7. Sometimes there's no good literature on this, whether you should just wait a month. The reason not to change it early is if you change it and things aren't well healed, you could lose the airway. You could get a false passage easier. The reason to change it is it forces you to inspect the wound, make sure everything is okay, make sure there's no brewing infection. So it's debatable when to do it. But you should always extend the neck and then have things ready in case things don't go well. When do you do the trach? This is also something that has a lot of literature on it. The ideal time is not established. The general principle is, and that says if you're going to be intubated for a while, you should have a trach. And for all the reasons we mentioned, that it's going to cause scarring of the larynx, that it's easier to wean. And then the literature says if you're going to have a trach be intubated for less than 10 days, you don't need a trach. In between 10 to 21, people don't know. And the question is, when do you say, okay, it's time to get a trach? You know, if it's day 2 and you think this person's looking for a long intubation, you just do it then. And that's what's been debated. There's a lot of prospective studies that are well designed, but it's very difficult to power it that would pick up small changes between people you trach early and trach late. And it also is very difficult to power because it could be that maybe neuro patients would benefit, but people who have MIs wouldn't. You know, that you could have different subsets. You really need a lot of literature to decide. And some studies suggest benefits for early trach and some don't. Many studies suggest a benefit for some aspect of early trach, like it's more comfortable for the patients, and they know that by less, they're asking for less morphine. Or there's decreased incidence of pneumonia, but not for others. There's almost no studies that show that there's a benefit for late trach, that you shouldn't do it. But there's nothing that prospectively, with a p-value of less than 5.5, 0.05, suggests definitely you should do an early trach. So there,
as you were mentioning about there have been so many studies and even trials, and then they've been looking at different aspects and durations. Initially, it was like more than 2 weeks or less than that. Now, even 7 to 10 days is the earliest trach, and then late is more than that. And the earliest trach, they mentioned there are some studies like NAC 25 and JAMA. There is some benefit like decreased length of ICU stay that has been very consistently shown.
Yes.
Some studies showed.
But the ICU stay is a little bit, it doesn't mean that the patient got better and left the ICU. Like here, the ICU stay, it's because a lot of it is you can't go to a nursing home without a trach. And so, it's not clear that they are actually any better. They're just in a different place.
They've been they showed even transition from ICU to even towards or to long-term care is easier if we do early trach on those patients who are anticipated to stay on a long-term ventilator. Yeah. In addition, there is some studies showing decreased pneumonia.
Pneumonia and pain are the two things that have been shown, but nothing else more significant. When you have like the observational studies, which are not prospective, they almost always show benefit for early trach, but there's such a bias that you can't really judge from that. If it's not randomized, did they pick the people they thought would get better? Did they pick the people who weren't at death's door to do the trach? If someone's really sick, you might not do the trach. And like I said, the prospective, they didn't find any benefit in terms of mortality and days in mechanical ventilation, but in a lot of studies, it trends towards early trach is better, but in none is there a significant p-value. But like I said, there's just so much of a lack of standardization and timing. You can't really do a meta-analysis because how do you define an early trach? Like some studies will define it day 3, some will define it day 7. So it's not really clear. And then in some studies, the real way to do it is you would say, we're going to establish that these people need a trach. Some of them we're going to wait. Some of them we're going to just trach day 3. And part of the problem is what they show is that people just can't guess who needs trach, because in the people who are the late trach, almost half of them don't wind up getting trach, either because they die before they get a trach or because they get extubated before they get a trach. So it's very tough to really to make this a prospective study. What are the risks? Because obviously part of that goes in, right? What's the risk of doing a trach? The complication rate in the literature is anywhere from 5 to 40%. The mortality rate's less than 2%. It's more frequent in children, severely ill, emergent situation. And you categorize it by early, which is operative or immediately post-op, and late. The intra-op, it's hemorrhage, you damage a structure, you create a false passage, airway fire, pneumothorax, you extubated too soon, or something related to anesthesia. So the hemorrhage, they say about 5% of times you get intra-op or post-op hemorrhage. Major hemorrhage is rare, but minor can interfere with identification and access. Like major hemorrhage would be hitting one of the great vessels. Like you can hit an EJ or an IJ, and not an IJ, but you can hit an anterior jug, and it'll bleed, and it might look like it's bleeding a lot, but you pick it up and you buzz it with a bovie and it stops. So those are really minor, but they just can lead you to getting in the wrong plane. And most commonly, it's an error of surgical technique. If you stay in the midline, you shouldn't hit any of these things. I always tell when I do the trachs, I tell the interns that, this is an 8-minute procedure, and it shouldn't take you more than 10. And you're not going to do it faster by rushing. You just do it faster by avoiding making mistakes. And so if you just don't make mistakes, it's an 8-minute procedure.
One thing I know clearly, not being surgeons makes the interventional pulmonologists who tend to do the percutaneous procedures a little bit more concerned, a little bit more conservative in some ways. But one of the things that I was always taught to do was to ultrasound specifically to look for a high riding nominate and to look at the CT scan, because that was sometimes the thing that would most commonly be a concern. Yeah, so I feel every case for a high riding anomaly. I don't do an ultrasound, but you can feel. And then, when it's easier because I'll cut the skin, so you can feel even better. And the only time I get concerned is when you come under the thyroid. If you're buzzing and it was a high riding, I think you could hit it. But sometimes you clearly see it, and you really got to think about it. And I've seen one. I had one where the anominate was like
if you did it in the second ring, you would have just gone right through the innominate. And so there I was worried about how it was going to heal, so I sewed the skin to the trachea so that the trach wouldn't rub against the innominate, because I was worried that that was going to rub in if the skin wasn't there, just rub against it and erode. But yeah, I think, you know, it's recognizing the things that could get you. And so even though I've done thousands every time, I'll feel for that, because I haven't had one, and I never want to get into the innominate. Pneumothorax supposedly happens like 2 to 5% of the time. In peds, much more common. One way people think is if you were cutting in the wrong place, you cut the upper aspect of the lung. But what people actually think is that they have forceful inspiration that leads to high negative pressure, and the air comes in through the wound and gets trapped. But you can have direct injury to the apical pleura or perhaps bleb ruptures. Intra-op, you can have, if you don't identify the trachea and you get off, you can cut a recurrent laryngeal nerve, you can get into the esophagus, you can put the tube somewhere else outside the tracheal lumen. I mean, all those things just should never happen, but they do, especially if you don't do a lot of trachs. If people don't do a lot of trachs, they get scared and things go wrong. If you do a lot, this should never happen. Airway fires, that's something that could happen. You want to make sure your O2 concentration is less than 50%. You know, we're using a Bovie, and we're doing it on the airway, and I always Bovie the trachea. I don't Bovie into it, but I just so that when I cut into it with the scalpel, it doesn't bleed. But it would be very easy to have it go a little bit deeper and get in. And so you always have to work with your respiratory therapist. Post-op, the delayed hemorrhage, the tube can get displaced. You can get a mucus plug. Fistulas, either tracheocutaneous or tracheoesophageal, tracheostenosis down the road, tracheomalacia, dysphagia. Tracheal damage, there's two mechanisms. The first is direct pressure from the cuff or the tip of the tube. And you have capillary flow is 30 to 50 milligrams. And the cuff can exert more than that. The modern cuffs exert a little bit less. Like historically, they had these high-pressure cuffs that would seal things off. But if you have someone who's diabetic, and you have someone who's sick, and you have someone who's hypotensive, then that's going to drop that. And it can be that the cuff occludes capillary pressure. And what happens, you get some ulceration, the cartilage is exposed, the bacteria come in, you get some necrosis, and that leads to stricture or tracheomalacia. And then people keep giving a bigger trach, but that doesn't, or inflate the tube more, and that doesn't necessarily solve it. So sometimes it's worth having a little air leak in a patient that is clinically stable so that you don't wind up in this situation. So you often get the stenosis at the cuff or the tip site, which is below the stoma. You get some granulation. You can also get stenosis at the stoma itself. If you move the trach around and things twist and you keep getting scarring here, you can get that. To me, the advantage, one of the advantages of doing an open over percutaneous trach is I think if you really studied it, you would find it's less tracheal stenosis, because I can make a cut in between the cartilage. I don't break it. I just spread it gently, and I think that there's less long-term damage to the trachea there. But you'd need a lot of patients to prove that. Late complication, massive hemorrhage from vessel is the big thing, the innominate or the carotid. It often happens either with a low placement of the tube or a high innominate artery. A lot of times these have a sentinel bleed. So if you're, see some real brisk, bright red blood from a trach that stops, maybe even shoots out, that would be something to be concerned about. And the arterial bleeding is clearly different than the venous bleeding. The venous bleeding can be scary, but arterial is different. When the peak incidence is a week or two after surgery, 3/4 happen in the first 3 weeks. This was just a study that I liked that looked at complications by specialty in a hospital system in the Midwest. Looked at 1,000 trachs. 2/3 were performed by ENT. 22% of the people died, not from the trachs. There was 1.4% interoperative complication, 5.6 early, 7.1 late, But if you looked by specialty, otolaryngologist versus general surgeon in general, sometimes plastic, it was much, much lower with otolaryngologists. And I think what that highlights is that you need to do a lot of these. And if you do a lot, the complication rate is low. You know, we've been doing the bedsides now, and we've probably done over 1,000, and we have essentially no serious complications. We have 2 pneumothorax, and the people were fine. No significant bleeding. And I think if you just do trachs the same way and you do them frequently, you really can cut down, and you're careful. Your rate can be very low. So this is studies looking at surgical versus perc trachs. Perc trachs, if you look at single center studies and you look at the data, sometimes there's better data, but in meta-analysis, the open surgical slightly looks better, especially if randomized trials are considered. This is looking at all the meta-analysis of randomized control trials. The things that favor surgical was inadvertent decannulation or tube obstruction. Things that favored perc was wound infection, scarring, and cost. The major things were not significantly different. In a meta-analysis, it looked at it, if you looked at just the randomized control, there was a 60% greater likelihood of early complications with perc trachs, and the 4 studies that randomized had lower early complications with bedside open. So it's very tough, again, because you often compare apples and oranges, and it could just be you're comparing different centers. It could be you're comparing different experiences. I certainly think that perc trach is a reasonable thing to do, and there's no data that shows that it's not. I like the open better. I think it prepares you for the reasons I'll tell you. I think it prepares you for the flash trachs if you need to do them. And you know, if you had all the easy trachs being done percutaneously, but then the obese patients and the sick patients and the flash patients being done by open, and those people aren't doing, and you're not doing as many, you're going to have worse outcomes on those patients. So, I mean, I think there's enough to go around, but I like doing them open. There's studies that look at ENT training programs, and almost all of them at one point or another did perc trachs, and almost all of them dropped perc trachs or open trachs. So how do you handle your complications? Always remember your ABCs. Make sure the trach's in place. Check the inner cannula. Remember, you can always mask ventilate. You can intubate most of these people. Not if it's laryngectomy. We'll go into that later. But you know, that's an option. But don't panic and rip out a trach and go to intubation. Like, go slow. You almost always have time. Suction. See if you can pass the suction catheter. I mean, you guys have bronchs in there now, right? Look and see. It's not that hard to get those. You have the disposable bronchs, right? I mean, those are pretty good. You can just throw that in and see if you're in place. If you have an air leak, you can inflate the cup. Make sure it's not like a mistake. You have a fenestrated trach, you have a broken cuff. Those are the most common things. Reposition the patient, extend the neck, and if it's asymptomatic, maybe do nothing. And if it's symptomatic, then consider going up to a larger trach. But just always be aware you can create this feedback loop where you put in a bigger balloon, that dilates it, it causes more damage, and you just need a bigger balloon. The trach fell out. If it's an old plate trach, you can put a obturator and resecure, make sure it's in place. ET tube goes in even easier. If you have a small ET tube, it goes right into a trach site really well. If it's a fresh trach, you might have a hard time getting it in, so intubate, call whoever did it to replace. Patient has had a free flap or something like that, you may not be able to intubate if they had a head and neck cancer and they got a big free flap in their mouth. So in that kind, you may have to try to put something in. And an endotracheal tube isn't a bad thing to put in. It goes in pretty nicely. I want to talk about trach versus laryngectomy because this has led to some issues here in the hospital. One of the most important functions of the larynx is not speech, it's the separation of food and air. It's very impressive that food and air come in the same space through the mouth, and then your body separates it very, very well. The air goes into the lungs, the food goes into the esophagus. When you take your larynx out, there is no connection. You remove that and you close and the trachea comes right out to the front. So all your air goes right into the trachea in a laryngectomy patient. There's no connection between the mouth and the lungs. So the mouth is only food. And so you can't intubate from the mouth. And so you need to know that it's a laryngectomy patient. We have a policy here that every laryngectomy patient has to have the sign above their bed that says patient has a laryngectomy, cannot be intubated by mouth. Doesn't always happen, but it happens pretty much. Ways you can tell the difference. If you take a trach out, it'll close because the skin will just heal. If you take a laryngectomy patient's trach out, which usually they do, it won't close. And that's because it's just the end of the trachea right to the skin. So it's not going to close over. There was one patient where they were laryngectomy and they had an airway, and respiratory came up, but like, don't worry, we were able to intubate. What they did is they put it in through the mouth, the tube popped out, they ripped all the sutures, stuck the tube out the neck, and it happened to get lucky enough to go back in to the airway. So my residents did not take a picture of that, but I would have loved to end the talk with that. So just always be aware, laryngectomy patients, there's absolutely no connection. This is the trachea. You can stick your bronch in there and you see right into the lungs, and if nothing goes up. So, you know, the more you know, the better you can serve your patients. Be systematic. Don't panic. Remember your ABCs. Don't intubate laryngectomy patients.
How many days after the trach is formed that it's safe to just put in back the trach again?
So most people say 3. You know, if you have a thin person and you're very careful, you could do it day 1 maybe. You know, what happens is the skin has to heal to the subcutaneous tissue, which has to heal to the trachea. And if you're careful and you took it out, you could probably put something in even day 1. But what happens is you get a little off track, and then the different planes shift. And now, you know, the hole in the skin isn't lined up with the hole in the trachea, and it's hard. But, you know, if that happened, like, you could always, we could get, like, just 2 of the retractors, take a look, and put it in.
What about like proximal and distal trachs?
The extra long ones?
The extra long ones?
Yes.
Next, like what, do you just put, like, let's suppose they plug or you need to actually change that, like, you can't just put a regular trach into that site, right?
It depends. You know, so, you know, the regular trach has a curve. You know, that's a good point. I should just have something here. So there's proximal, there's extra long proximal and extra long distal. And the extra long distal is for people who have tracheostenosis. And if the tracheostenosis is here, the distal part of the trachea is longer. And so the curve is the same curve, but then this part goes down to here. But if the patient's very obese, you don't need that extra length down there. You need the extra length at the start. And so you have the proximal extra long trachs that have, this section is very wide. So the question is, it would really depend. There are some people who, you know, it depends on how big they are. There's some people where their neck would be so big, you can't get the other one in. There's some people who, they're obese and maybe the proximal extra long fits better, but an 8 would work for short term. If you really are worried about that, I would use an ET tube, because an ET tube is flexible enough that it could serve as a proximal or a distal extra long, and just shove an endotracheal tube in.
That's an outpatient usually question, but for decannulation purposes, how do you manage the patient, manage them as outpatient?
Yeah, so what I do for decannulation is, you want to make sure, first of all, it depends why they had the trach. Like, let's say they had the trach for pneumonia. If they had pneumonia because they have terrible COPD, and this is their 3rd pneumonia in the last year, and they're actively smoking, you could probably bet they're going to have another. And then I might say, I could decannulate, but I'm not going to, because they're just going to need another trach. But let's say they just had, you know, something where it's in the past. In general, you want to make sure that they can tolerate the trach being out. For us, because a lot of the reasons they have trach is because of airway obstruction. You want to cap it. So what I do is you put a plug over it. I put in like a 4. I downsize it to a small one, and I cap it. And I first cap it for 12 hours during the day and make sure they're okay, and I uncap at night, and then I do 24 hours. And if they've tolerated that, I decannulate the trach. Sometimes I admit people for that if I'm not sure they're going to do well or if they're not good. If I'm not sure they're going to follow up, or if I'm not sure they can handle or eat the instructions. Anything else?
Do you use any of the trachs that have the fenestrations so people can phonate?
Yeah. So especially a lot of, I try to avoid it, and I think most people do. And the reason is that most people are fine with phoning around a 6th trach or a 4th trach. And if you're not, it's only for the people where, let's say, there's some tracheostenosis or something that's causing it where they really can't phonate around it. The problem is that where the fenestration is often rubs against the trachea and causes granulation tissue at that area. So it can cause more trouble. So if you can get away with not using the fenestrated trach, I think it's much better, because it's like a sharp edge. And every time if you move or you turn, it leads to granulation tissue and can make things worse. So, it would have to be somebody that failed the trial of like a 4 before I went to the fenestrated trach. But yes, you definitely do use them. But I found that most people don't need them.
For people that you have to, I think it comes up a reasonable amount where you have someone come in with an uncuffed trach and now require ventilatory support and need to get switched over to a cuffed trach, but you don't know much history about the trach. Like, what do you think about changing over an airway exchange catheter? Or do you...
I wouldn't.
Okay.
Because I think sometimes that can lead to more trouble, because unless it really fits the trach perfectly. Because what can happen is, the obturator is a smooth thing that finds the right plane. But if you don't have the obturator and you're doing it over a catheter, now you have like a blunt, somewhat sharp edge of the trach that I think can lead you into false passages. If the trach is not sewn into place, you can bet that it's not a fresh trach. Because nobody's going to cut the stitches like day 1 or day 2. I stitch every trach. Usually I cut the stitches either day 5 or when I change the trach. So if you don't have stitches in, you can assume that it's probably not a fresh trach. I can't say that 100% of the time, but I can't imagine why someone would remove the stitches before day 3.
Like other old trachs you get worried about changing, like people with like the masses that'll fall in, or?
Only, if you had a trach for a tracheal tumor, I guess as you would know that, and that would be very rare.
That's a rare enough thing. Like most old trachs, you would just change and be comfortable.
Could you ever get into trouble? You could, but I think that it's rare enough that you'd get into trouble that I think by not having the obturator in the trach and having that blunt thing going in, you'd cause more trouble than you.
I hope it never happens, but suppose if nominated doctor gets damaged in a long-term trach, so what should be
the best thing to do is, 1, you blow up the cuff because you don't want to drown. Sometimes that even puts enough pressure that could stop it. 2, you want a finger pressure. Direct finger pressure, just plugging the hole. And then 3, you probably would want to, in order to get finger pressure, you might need to remove the trach, put finger pressure, and then intubate from above. But it's direct pressure. So blow up the cuff, see if you can get direct pressure, but if not, you may need to pull the trach to get direct pressure, and then intubate from above. And then you go down, then call surgery and probably go to IR. And hope you're not the one who's fingers on there, stuck there. Never know. All right. Listen, do you guys ever have any questions? If you want to watch trachs, do some. come join us anytime.
Thank you very
All
much.
right, thank you.
Appreciate it.
Good night.
Thanks. Schiff, sorry.
It's all right, dude.